Hello, I'm Bobby Jean Schweitzer, and I'm presenting Anesthesia for Ambulatory Surgery, Part 3. The lecture module here will focus on discharge of patients. So start with a question. A 37-year-old female comes to a freestanding ambulatory surgery center for a knee arthroscopy and anterior cruciate ligament repair. Which of the following is associated with the need for prolonged stay or unanticipated postoperative admission? A, the intraoperative use of ketorolac. B, the intraoperative use of antiemetics. C, a history of postoperative nausea and vomiting. Or D, a preoperative femoral nerve block. And the answer is C, a history of postoperative nausea and vomiting. Answer C is correct because postoperative nausea and vomiting is the single highest cause of unanticipated postoperative admission after ambulatory surgery in patients who have related to anesthesia, in patients who undergo anesthesia in ambulatory surgery center. Answer A is incorrect because actually the use of ketorolac, which is a nonsteroidal anti-inflammatory agent, is associated with opioid sparing and therefore typically a lower risk of post-op nausea and vomiting or sedation. Answer B is incorrect because administering antiemetics to patients decreases the risk of nausea and vomiting and would therefore decrease the risk of admission. And answer D is incorrect because studies have shown that patients receiving peripheral nerve blocks can have a very limited limited use for postoperative opioids, which decreases the risk of nausea and vomiting, and also excellent pain control. Since a patient undergoing a knee arthroscopy would typically be using crutches anyway, having a numb leg would not delay the discharge time. So let's talk about discharge criteria. So typically for patients to be discharged from a PACU home, they should be alert and oriented, not necessarily oriented times 3 if they did not come in oriented times 3, but oriented to their baseline. They should have stable vital signs. Their pain should be adequately controlled. They should have minimal to no post-op nausea and vomiting. They should be able to walk without any significant dizziness. There should be no unexpected bleeding from the surgical site. Oral intake and voiding on a case-by-case basis may be important. Discharge instructions and prescriptions should be provided to the patient and their escort, and the patient should be accepting of their readiness for discharge. So post-op nausea and vomiting increases the cost of ambulatory surgery due to delayed diagnoses delayed discharges and hospital admissions. It accounts for 0.1% to 0.2% of all unanticipated admissions. This may seem low, but considering that 31 million patients typically undergo ambulatory surgery every year, this translates into 30,000 to 60,000 admissions for nausea and vomiting alone. Aggressive prophylaxis and treatment are always prudent. So post-op nausea and vomiting risk can be divided into patient risk and surgical risk. Patient risk consists of a previous history of post-op nausea and vomiting, female sex, a non-smoker, history of motion sickness, and perioperative opioid use. Surgical risks are related to laparoscopic surgery, laparotomies, plastic surgeries, major breast surgery, craniotomies, ear, nose, and throat procedures, and strabismus surgeries. So post-op nausea and vomiting prophylaxis should be given based on the patient's risk for post-op nausea and vomiting. Patients considered at low to intermediate risk typically still have an incidence of nausea and vomiting of 20 to 40%. Patients at intermediate to high risk have a risk of about 40 to 80% chance of having post-op nausea and vomiting. Those at the highest risk, more than 80% of them will vomit. So patients at low to intermediate risk are those who typically have 1 to 2 risk factors. Intermediate risk patients have 3 to 4 risk factors, and high risk patients have more than 4 risk factors. And those are the risk factors that we discussed on the previous slide. So for those patients who are considered at low risk for nausea and vomiting, it's still recommended that those patients receive prophylaxis because again, they have a risk of about 1 in 5 to 2 in 5 chance of still having nausea and vomiting. So it's typically recommended that one give either 1 or 2 of the following: dexamethasone or a 5-HT3 blocker such as ondansetron or dolasetron or a scopolamine patch. Those patients who had intermediate to high risk should be given a 5-HT3 blocker plus dexamethasone plus scopolamine, and one should consider avoidance of general anesthesia and narcotics. So those at the highest risk are the most difficult to prevent, and those patients should definitely receive a 5-HT3 blocker plus dexamethasone plus scopolamine plus total intravenous anesthetics with avoidance of inhalational agents and avoidance of narcotics and general anesthesia if at all possible. So another question. This is a 52-year-old who is scheduled for an upper GI endoscopy. Which of the following would prevent a patient being discharged home if the ambulatory surgery center used post-anesthesia discharge scoring system, or PADS scoring, for discharge criteria? A, the patient had a blood pressure that was greater than 30% of their baseline blood pressure. B, bleeding which required at least 2 dressing changes. C, heart rate greater than 35% of the preoperative value. Or D, the patient has a visual analog pain score of 7 or a VAS score of 7. And the answer is if the patient had a visual analog pain VAS score of greater than 7. So the answer D is correct because a VAS score of greater than 7 would be a 0 of the on the PAD scoring discharge summary. Answer A is incorrect because vital signs must be outside of 40% of the preoperative baseline to have a PAD score of 0. So as long as the other 4 components had scores of 2, the total of 9, which is what's required on a PAD scoring to be discharged, would be met. Answer B is incorrect because bleeding, which required 2 dressing changes, is worth a PAD score of 1. So as long as the other 4 components had scores of 2, the total of 9 required for discharge would be met. Answer C is incorrect for the same reason that answer A is incorrect. So this is a modified Aldrete scoring system, and as alluded to in the previous slide, one requires a score of 9 or greater for discharge. A modified Aldrete scoring system looks at 5 different components: patient activity, patient's ventilatory status, patient's circulatory status, consciousness, and oxygen saturation. You can see that each of these components gets scored at a 0, 1, or 2. So therefore, if one has at least one of these at a 0, it would be impossible to meet a score of 9. So you can see that, if one is moving all 4 extremities, they get a 2. Moving only 2 extremities, you get a score of 1. If one can't move at all, it's a score of 0. This is also, assuming that the patient came in being able to move all of these extremities. This has been considered a weakness of the Aldrete scoring system. Ventilatory status is assessed by the ability to breathe deeply and cough freely, which gets a full score of 2. If one is dyspneic or has shallow or limited breathing, one only gets a score of 1. If one is apneic, then you get no score. Circulation, if the blood pressure was within 20% of the pre-anesthetic level, one gets a full score of 2. If the blood pressure was within 20 to 49% of pre-anesthetic level, one gets a score of 1. If the blood pressure was within just 50% of pre-anesthetic level, that scoring system is a 0. This has also been considered perhaps too lenient, that one can have a blood pressure that is as far off as 49% from baseline and still get a score of 1. Consciousness is assessed by if one is arousable on calling their name, a full score. If the patient doesn't respond at all, 1. And oxygen saturation is scored at, it doesn't respond to calling, but is awake. But is not unconscious. Then it's a 1 if they only respond to painful stimuli or physical stimulus. If they're not conscious at all and do not respond to anything, it's a 0. Oxygen saturation, if one maintains an oxygen sat of greater than 92%, a full score of 2. If they need oxygen to maintain that O2 sat at greater than 92, it's a score of only 1. And if the oxygen saturation is less than 90%, even with oxygen, then the patient gets no score. So this is the PAD score, and this was this scoring that we talked about in the question. And this is different than the modified Aldrete that we just talked about. But it's similar in that one needs to attain a score of 9 or greater to meet discharge. And one assesses 5 different components, and the scoring is between 0 and 2. So that is the similarity between PADS and modified Aldrete, but the 5 different components are different. This looks at vital signs, activity, post-op nausea and vomiting, pain, and bleeding. If one's vital signs are within 20% of preoperative baseline, then one gets a full score of 2. Within 20 to 40% of preoperative baseline, a score of 1. And if outside of 40%, a score of only 0 or no score. Activity, rather than looking at whether one is moving extremities, one looks at total activity. If one has a steady gait and no dizziness, or they have returned to their preoperative level in a patient who perhaps was wheelchair bound or paralyzed, they get a full 2. If they require assistance that they did not require coming in, they get only a 1. If they are unable to ambulate or unable to be assessed, they get no score. Post-op nausea and vomiting is scored as a minimal or mild to moderate to severe. If there's no treatment necessary, they get a full score. If the treatment was necessary but effective, they get a score of 1. And if they have severe nausea and vomiting and treatment was not effective, they get a 0. Pain is assessed on the typical visual analog scoring system that we're all familiar with. If the score is 0 to 3, which is considered minimal or no pain, they get a full 2. VAS score of 4 to 6, which is considered moderate pain, they get a 1. And VAS scores of 7 or 10, they get no scoring for. Bleeding has to be either minimal to get the full 2 points, and minimal is no dressing changes. If they have moderate or up to 2 dressing changes without further bleeding, they get a score of 1. And if they have severe bleeding or 3 or more dressing changes, then they get a score of 0. And again, one must have a score of at least a 9 or 10 to be discharged. So is oral intake important before the patient goes home? Not necessarily. Frequently, oral intake is a comfort measure, but oral intake should not be mandatory. In fact, children that are made to drink before discharge have a higher incidence of nausea and vomiting rates than those allowed to be discharged without drinking. Patients should be well hydrated, of course, intravenously prior to discharge. Likewise with voiding, which used to be a common requirement in the past before one can be discharged, it's now felt that low-risk patients can be discharged safely without having voided in the PACU. They should be given clear instructions that they need to return or go to an emergency department if they have not voided within 6 to 8 hours. And this includes patients who have undergone spinal anesthesia or procedures with a higher risk of voiding, with a certain risk of voiding in the past have been required to void. This is felt to no longer be the case. Even patients who have had spinal anesthesia, if they've had a short-acting spinal, and patients who have undergone procedures with a low risk of urinary retention can be discharged home without voiding. The use of ultrasound to assess the amount of urine in the bladder is becoming increasingly more commonly used, and any patient who has a bladder volume that's less than 300 cc's is typically not going to have an urge to urinate and should not be considered to have urinary retention and can be discharged safely home. Those with bladder volumes of greater than 300 cc's typically should either wait until they can void or should be straight cathed. Let's do another question. You are called to assess a patient who is recovering from a general anesthetic after a breast reduction, and she is in the post-op anesthesia care unit, and they want to determine whether the patient is ready to go home. Which is the most important question you can ask her? A, have you voided? B, is your pain well controlled? C, have you drunk 8 ounces of liquid? D, have you required a dressing change? And the answer is your pain well controlled? So answer B is correct because assessment and management of pain is a component of discharge criteria and improves patient satisfaction and avoids readmission. Answer A is incorrect because for most surgeries requiring a patient to void before discharge just delays time to discharge, but it does not prevent adverse events. Answer C is incorrect because requiring patients to drink before discharge may increase the risk of nausea and vomiting. And answer D is incorrect because dressings may need changed for a variety of reasons, and even one dressing change for bleeding has not been shown to predict risk of readmissions. Let's talk a little bit about continuous nerve blocks in the ambulatory setting. These are increasingly commonly used. They are generally very safe. It is important that patients have an emergency number to call with questions or problems. It is important to follow up with patients to ensure that the block has resolved and there's no residual neurologic deficit. And it's important to ensure that patient knows how to remove their catheter and determine whether it's intact if one used a continuous nerve block catheter. Thank you very much for your time and attention.